So we were dispatched to a 40-year-old male, fell off a roof 6 metres onto the concrete driveway, landing on his occupant. He was water blasting of a 2-storey house, slipped and fell off, and a neighbour called 111. The scene wasn't safe due to all the water around, so we've moved into the back of the ambulance. There is no patient medical history, previous medical history. However, ABCs are okay, and our secondary survey or rapid trauma assessment, we see that he has an isolated injury to the back of his head, about a 6 centimetre boggy patch. Patient is lying supine. He is posturing and extending, restless and combative, and moaning and holding his breath and grunting. We have vital signs: heart rate of 50, BP 160/90, rest rate 12 and irregular, BGL 7.6, and a temperature of 37. We're not too happy with Tony's stats, so we'll call for backup. We'll need an R50 for RSI, please, Sarah.
Requested RSI to prepare for, please.
Awesome. How far away is he?
10 minutes.
Wonderful. Okay, so GCS, we're looking at his eyes. They're spontaneous, so that's a 4. Verbal, he's making incomprehensible sounds, which is 2. Motor, he's got a decelerate posturing, so we'll give him another 2. So we've got a total of 8, which is under 10 for a requirement for RSI for intubation. We're gonna recognise and treat his TBI accordingly, and we will strap his head amongst 2 towels so we can try and suspend that cervical spine somehow. We just need to be checking on the chain Stokes triad as well. At the moment we're bradycardic and hypertensive, so we just need to keep an eye on the breathing and make sure it does not become too rapid. We have gained bilateral IV access, and we have given 4 milligrams of morphine, which we've done the drug checks for, and also we have connected to a 1 litre bag of saline, again with drug checks done. The saline is just to keep the vein open, as we have a systolic of 160, which we're quite happy with right now. However, if it does drop down to less than 120, then we'll think about opening that line right up. So we're just going to go through our RSI preparation checklist.
Attach nasal prongs without oxygen.
Nasal prongs without oxygen.
Pre-oxygenate using reservoir mask at 10 litres or manual ventilation at 10 to 15 litres, with PEEP set to a minimum of 5 centimetres of water.
For this moment we have an OPA to secure the airway, and we have a non-rebreather mask on at 10 litres to pre-oxygenate.
Attach ECG, NIBP and SpO2.
ECG is on, NIBP is on, and SpO2 is on. Yep.
Prepare capnography if this is available.
Yep. We have our ETCO2 connected to our bag valve mask along with PEEP set at 5.
Position the monitor so that it can be seen, leaving space to the right of the patient's head for intubation equipment.
Yes, we've got that. All equipment is clear.
Gain IV access, preferably in 2 sites.
Bilaterally is done.
Prepare running line of 0.9% sodium chloride.
Which is hanging now.
Position the patient for optimal airway control. For example, consider placing a folded towel under the head.
Which we have done.
Place an ETT holder with the strap undone under the patient's head.
Done.
Ensure suction is working and turned off.
Suction is working and it is under the right shoulder.
Prepare manual ventilation bag with PEEP valve attached if not already in use.
PEEP, ETCO2 and connected to high flow.
Obtain a set of vital signs.
Yep, so we're going to do another set of vital signs just now and nothing has changed.
If possible, update the responding ICP with patient's condition and vital signs.
which we will do now. If you do that, Sarah, and let us know what the ETA is.
Copy that.
Um,
ETA is in 5 minutes.
Great. During the intubation, the ICP might ask me to help with a few things. One would be the Burt position, which is a backward, upward, rightward pressure to help with the anatomical alignment of the, for optimal visualization of the vocal cords. Another one might be the bougie ETT. So pretty much I'm just going to be passing over the ET tube on the right side of the ICP and just sliding it down, sliding the ET tube down the bougie while the ICP has the laryngoscope. Another one could be a failed ETT. We all will assist with this one, and we would have our own roles designated. We would need to re-oxygenate for 15 seconds, manually ventilating with high flow bag valve mask and high flow nasal prongs with OPA, possibly MPA as well. In this case, an MPA might be contraindicated due to the basal skull fracture, trying to oxygen load onto the patient. And then we'll have one more try. If that doesn't work, then we'll consider an LMA if possible. If all that then fails, then then the ICP may consider cricoid thyroidotomy, in which we would make a small incision in the cricoid membrane. Yeah, thank you.